And now on the line from Boston is Dr. Liam Curran, and we're going to talk about the issue of fetal alcohol spectrum disorder, or FASD. We're going to talk about it in some areas. Liam, first of all, welcome to the program.
Hi, Darren. Thank you so much for the invite, and I'm delighted to be here and to talk to you about this kind of. It's a difficult topic to talk about, but it needs to be talked about. Yeah.
This is only my first time, well, not my first time, but trying to sort out a Zoom call. I'm not very au fait with Zoom. Okay, we'll move ahead and move on to our interview. Okay, Liam, after 15 years working in the FASD field, what drew you into this area of advocacy and social work practice?
Yeah, Darren, I suppose, for many people, they wouldn't understand maybe that as social work on the front line, we often deal with issues of substance misuse and alcohol, et cetera, in our practice. It was about 15 years back when I was a principal social worker in the UK that I had a very complex pre-birth risk assessment of substance misuse, child protection. And it was that case that really triggered my interest in the whole area of what happens to the unborn in terms of drug and alcohol exposure, etc. So it was from there that I really moved into it. And when I came back to Ireland and practice, I think in 2001, I actually went into Trinity to do a master's study. And in that study, the question of the study was, does drug and alcohol use in pregnancy, is it a child protection concern? And it was a qualitative study of Irish professionals. And that study, the finding was that there was a level of palpable concern in the front line in Ireland with that topic. And that study was then published by the Society for Knowledge in Ireland. And yeah, I launched it. We actually went into a book about the unborn, and, Judge Catherine McGuinness was very complimentary of my work and wrote very nice words about me, about the work I was doing. I suppose, Darren, it's a long answer, but then I kept going on and I did more work and I did more publications. I think it was 2013, I launched a little book called Understanding Fetal Alcohol Spectrum Disorders, a guide for parents, carers and professionals at the Mansion House. And it was then Senator Gillian Van Turnhout that launched that book. And again, was very grateful to Gillian Van Turnhout because she acknowledged that, yes, this was an issue that Ireland needed to kind of grasp and deal with. And so, but I guess a lot of my work then, Darren, was with the foster carers and the adoptive parents. I did CPD for social work in Ireland in that period. But a lot of the foster and adoptive parents were very angry with social work because social work wasn't giving them what they wanted. And that was what drove me into the PhD, which I tried for in Ireland, but I couldn't get it. So I eventually applied to Canada, and I got it in Canada. And Canada was very, very good to me. They gave me a full fellowship of funding to do the PhD. And so I was But again, the PhD was a qualitative study of Irish social work, allied health and foster parents. Unfortunately, I returned that back to TUSLA in the middle of the pandemic, so I'm not sure how it's been received,
Okay. As you said, talking about Ireland there, much of your work comes from Ireland and focuses on lived experience. Why was it important for you, Liam, to centre caregivers, foster families and adoptive parents in your research?
I think, Darren, there's an overwhelming body of evidence that points to the fact that children that are impacted by prenatal alcohol exposure, A, they enter the system, but B, they ended up mainly in foster care and they go into adoptive families, etc. It's kind of, currently we have a very high focus on that population. And so, but I suppose my argument in the process now, because of my PhD, as I kind of say, children don't appear in foster care or adoptive families through osmosis. They come in through social work intake. They come in through initial screening, assessment, and care planning actions of the child welfare piece. And that is, I believe, a major missing gap in the narrative at the moment that we're not focusing on, is that entry into the system before the child gets placed out into foster care, etc. Because if we had better screening and better understanding of that process, the children would be better placed in terms of having the quality of caregiver that is able to manage this neurobehavioral presentation. But I suppose what I'd want to say to your listeners, Darren, is that fetal alcohol is from mild to severe. It has a wide spectrum of how it presents in the child. Many of the children on the mild end can actually do very well and can be, with minor little accommodations, can do well. The moderate to severe end, unfortunately, they do not do well. And again, it's because we are not talking about that end of the spectrum. And even you've had guests on here, and they probably would have talked about that mild end. But again, I'm saying that it is a spectrum, and we have to understand that there is a serious end to it as well. Now, my doctoral study focuses in that spectrum of what's happening in child welfare system, in that, unfortunately, globally, we're seeing child fatalities connected to fetal alcohol, where the children are in the system being misunderstood, but because of their impulsivity, their mental health, etc., they're entering into risky situations, and so they end up on, in coroner's reports, basically. And so that's the real issue of the child welfare system, and where the child welfare system needs to kind of get a hold of in terms of the professionalism of the issue.
Okay. Am I right in saying, Liam, that there is a huge over-representation of people with FASD in our previously, at one stage, in our criminal justice system in Ireland and around the world?
Absolutely, Darren. Unfortunately, AIDS is a significant population of these children in our child welfare system at the moment that are undetected and that are unseen. Those children are graduating into the juvenile justice and indeed into the adult justice systems. And again, Darren, it is worrying that we are actually 58 years in the research. And it is worrying that we still don't see this, that we still don't want to acknowledge it, that we still kind of believe that. And I suppose I'll say to you, Darren, that what was said to me is that, I suppose in context, up to 90% of these individuals that are impacted will have no visible feature. They will have a brain anomaly, a brain impairment issue. The problem is that, again, those children are going through the system and being labelled as everything other than fetal alcohol. So trauma, ADHD, all these other more acceptable labels are placed on them. And this is why, again, that the child welfare system is seeing these dramatic failures globally in a system, because the kids are being mismanaged, mislabeled, and left to kind of struggle on their own. Yeah?
It's a huge issue, and we're talking a lot about Ireland, but in Ireland, the issue of FASD, it does actually affect a lot of people, doesn't it?
Oh, it does. And it affects every system in Ireland, unfortunately, because, again, Darren, one of the things that we don't do in the narrative regarding fetal alcohol, we do not connect the dots between what the epidemiologists say is the alcohol rates in pregnancy and what the potential prevalence rates could be in our systems. Now, Darren, I don't know if any of your previous talkers talked about, we have 3 very significant studies in Ireland on alcohol and pregnancy. We have Dr. Siobhan Barry, who did the Coombs study, which I was at was the launch of that study back, I can't remember when now, 2006, 2007. She found a 62% in a longitudinal study. Then we have Mullally at Trinity.
62% of parents drink alcohol?
In pregnancy.
62%? Oh my God.
Well, wait, it's getting a little higher because Mullally in Trinity did a study and came in with an 80% alcohol rate in pregnancy. And then O'Keefe in Cork came in with an 82% alcohol rate in pregnancy. Now, Darren, what your members your listeners need to understand is that is any level of alcohol use in pregnancy. That is from the one glass of Chardonnay to the heavy drinking in pregnancy. So it's the whole gambit. I think what the issue is, again, is that there is a belief somehow that low-level alcohol use is safe. And that's not true. There's a misinformation in Ireland that would say that the third trimester is safe because the child is now formed. Darren, most people understand that the fetus is developing, its brain is developing in the final trimester of pregnancy. Alcohol as a teratogen, it travels through the umbilical cord into the child's bloodstream and to the brain. The third trimester poses the highest risk for brain impairment. And one glass could be, because it's a Russian roulette in that context. And that's why all the public health information is saying no known safe level of alcohol in pregnancy. Now, again, Ireland is grasping with this at the moment. I would like to compliment the HSE in this because the HSE is doing some really good work. On May 18th, they just announced a new video and information on their website, etc. And they're clearly saying no known safe level in alcohol. So the HSE is trying to do the work of prevention, and they should be commended for that. I know, there's an issue in Ireland at the moment about labelling and the whole delay with the labelling of. Now, yes, the labelling of the woman with the line through it in pregnancy, that is, I think since 2018, I think Leo Varadkar brought it in legislation, and we're still dealing with it. I think the problem, Darren, obviously, is that we are part of the European Union, so we can't do things unless the European Union confirms, and it's throughout the European Union. And again, this is a sensitive topic to get agreement on. But I'm saying the alcohol labelling and the woman in pregnancy is only one facet of prevention. And I'm delighted to see the HSE doing the work they're doing. But there's a lot of other things we could be doing as well. I would love to see an A4 leaflet go into the SPHE program in second level education, because adolescents will take this information on much quicker than adults will. They're more absorbent of the messages. So again, a simple leaflet in a health promotion pack in the SPHE program, because we have to shift that culture. We have to nudge that culture of alcohol and alcohol in pregnancy, which is contextualized within. Darren, I think you and I know we have a love affair with alcohol. We are revered for it around the world as a culture. So how we shift and get to the protection of the unborn within that context is going to take many, many different strands of approaches and interventions to try and get people to understand. And what I will say to your listeners, I have co-delivered education with birth mums. I've heard their stories. There is no mother that wants to deliberately or intentionally harm her unborn child. But what we have is a lot of misinformation in society that women fall into. And so, that is why the HSE's work is so important. And that's why we should be looking that direction. Yes, the label on the bottle is important, but it's not the be-all and end-all of prevention. There has to be many, many other strands and caveats of doing that.
I find it remarkable that actually a majority of women in Ireland drinks somewhat during pregnancy. I wouldn't have thought it would actually be the majority.
I can only say what I referenced the what the research says. And those 3 studies are there in Ireland. And, you know, you would have to have those onto your podcast or onto your interview and ask them about their findings and how they came to those conclusions. But that's what they're saying. I think it's not beyond the realms of possibility that their findings are correct because of our deep love affair that we have as a culture with alcohol, that, you know, sadly, women's health is, you know, we're in a patriarchal society, so women kind of will fall victim to that, you know.
And I only heard recently, actually, that men and women are not supposed to drink alcohol for a period before conception as well. Is that true, is it?
I think that, you know, there's some little evidence out there about it affecting sperm count, etc. But I don't necessarily kind of follow on that. I say that men, it's not necessarily about the conception piece, but men should support women in abstaining during pregnancy. And if you're the husband, then yes, you should support by not going to the pub or not going to, you know, by supporting the woman in pregnancy. And I would like to see men do that rather than get into the minutiae of whether a male sperm can carry fetal alcohol or whatever. I don't necessarily follow on that science. The science is very clear, Darren, that alcohol is a teratogen. It travels through the umbilical cord. It enters the fetal bloodstream, and that's where the damage is. And so I think the science is not clear that men can carry fetal alcohol in that way. It's not clear.
Liam, you often speak about FASD through a social work and disability lens rather than a purely medical one. What does that shift in perspective mean in practice?
I think, Darren, again, I'll come back to the fact that we have nearly 6 decades of research. There is a major issue in the research at the moment that I mentioned there that up to, well, it's 85 to 90% of children will never have visible features. They won't have dysmorphic or sentinel features. They will have a subtle brain injury from mild to severe. There is no clinical guideline that diagnoses that hidden brain injury. And that is the issue for child welfare, because unqualified narratives will tell you early intervention diagnose. But the vast majority, and I'm saying up to 90%, will not reach the criteria for diagnosis because they have no visible feature and there's no documented evidence of prenatal alcohol exposure at the time of their conception and birth. Because Ireland is not routinely collecting that information. Now, when I was doing the training before my PhD, you'd be probably surprised to hear that the Diageo funded the training of 10,000 midwives in the UK. And what they were doing by that funding is that they wanted the midwives to document alcohol exposure in prenatal alcohol records, so that record would be there if the child presented at 9, 10, 11 years old with this condition, that you can go back and find that record. So my argument, and I brought forward a paper and a 5-step screening program, which I kind of, some people in Ireland are reading. They may not necessarily grasp it, but we need to be shifting the narrative from early intervention diagnosis to early intervention and assessment. And that falls within the biopsychosocial model of disability and the social model of disability, not the medical model of disability. I will also say, Darren, that in 15 years, I have seen families get a diagnosis and have more difficulties after the diagnosis because more doors are closed to them. Because the service will say, oh, that's not our criteria, fetal alcohol. So I literally have had a caregiver tell me she ripped up the diagnosis these are expensive processes. I think 3,000-4,000 euro to get a diagnosis. But then if, the false solution for the caregiver is that if I get a diagnosis, I'll get the services. No, unfortunately not. Because if the services are not there before diagnosis, they're not there after diagnosis. Because services are not delivered by an ATM machine at the corner of the street. They're delivered by allied health professionals. They're delivered by social work. And if they're not upskilled and trained to understand what fetal alcohol is, then the services don't exist because they don't get, I'm obviously hopeful that my research and the publications I've put in is helping professionals. The little book that I published in 2013 with Gillian Van Turnhout, I think is a really good starting point for professionals to get a grasp of that. And I wish they would read that book and they would read the research that's published because that will help to upskill and help professionals to grasp the complexity of this issue. And it is very complex. Darren, when I delivered CPD education to social workers in Dublin, it was inevitably that the program was evaluated as needing 2 days. And that will tell you how complex this is. Because, there's fetal rights, there's maternal rights, there's legalities, there's values, there's ethics, there's a whole range of that you have to put into professional education for professionals and social workers to be able to grasp this. I did role play with social workers on how to talk to a birth mum about alcohol and pregnancy. Because that's a major, major challenge for the social work profession to do that. So again, if you're not going to train them, if you're not going to upskill them, then how can they do that? And how can they do the work that's needed? That's kind of why I'm situating myself in the kind of the biopsychosocial social model of disability approach to fetal alcohol. I've seen too many children get diagnosed, and I see it in my services now. Many families come to me, the child has been diagnosed, but they can't get services. So they come to me for the kind of the neurodevelopmental screening process. I do them, and the caregivers will often say, oh my God, this makes perfect sense. Now they're seeing in kind of black and white in paper. I said the last one I just did this week. The child had 6 areas of strength and 3 areas of deficits. Again, the brain, the 9 domains. Darren, the 3 areas of deficits were overpowering the 6 areas of strength. This was the first time the caregiver had seen this in black and white, in paper, on tape. Now we knew that we can focus on the 3 deficits and we can accentuate the strengths. So that is what a social model and a biopsychosocial model of intervention is. But yes, Darren, it's a hard sell because we are so caught up in the medical model of fetal alcohol that this approach is almost seen as kind of out of space or something. But yet I'm seeing amazing results. And I'm seeing very happy caregivers because they're finally seeing something in black and white in their hands and they know what the issue is. So
I know you're based in Boston at the moment, but in Ireland, would the first step need to be for the Department of Health to recognise FASD as a disability?
I think, that I say my research is back there. I'm not sure how it will be interpreted because I'm coming at it from this biopsychosocial approach. I think at the end of the day, the Department of Health and the HSE, etc., I think there's a level of recognition appearing in terms of what, again, I'm reading on the HSE website, etc. I think the problem, again, is that I would like to see the Department of Health and the HSE acknowledge the social model of disability alongside a medical model of approach, and that the two approaches have valid approaches in the system. The vast majority of these kids will never reach the criteria for diagnosis for the reasons I outlined. And therefore, leaving them dangling because they don't reach the criteria is not helpful. Now, my 5-step that I talked about that I do in practice here, that was recommended by that's my work. Dr. James Patrick recommended something similar in Australia after the death of a child in the care system. And he recommended that professionals should be trained on neurodevelopment screening tools prior to diagnosis. And I think that is what is missing in the narrative. And it's missing because if people are not FASD informed in making their decisions at the Department of Health or in HSE, then they're not going to understand that there is a whole biopsychosocial model that needs to be acknowledged in the discourse. Again, like I'm saying, that the interviews in Ireland and with the social workers and with allied health, I mean, my experience is that they are struggling. They're struggling with this issue. And I think, I'm aware of the stories and I'm aware of the foster carers and the adoptive parents. But I'm also saying I'm aware of the social workers in terms of everyone is struggling in this. And I think it's because there's a lack of coherence in how it's viewed. Now, I think Ireland is at a very formative stage of acknowledging fetal alcohol. What I would like to see is the HSE, TUSLA, Department of Health, Department of Education sitting down at the table and actually looking at this through a professional lens to ensure that we're rolling out education or prevention that is approved, that is empirical in its evidence. Because otherwise we can end up just doing sound bites here and there. But that's not helpful. That's not helpful because, Darren, your listener and you can jump to the conclusion that if we have that high level of alcohol use in pregnancy, then it's not a stretch in imagination to understand that we may have a high level of birth mums in Ireland that are struggling with the after effects and the outcomes of alcohol in pregnancy. And birth mums are the most stigmatized and blamed, and the research is there to show that. But again, if they're in a culture where they're getting mixed messages, one has to ask, is the blame appropriate? Is the stigma appropriate? If women are being told that the third trimester is safe, etc., etc.
I think it would, when I say be particularly useful, I don't mean solely, but I think it would be very useful or particularly useful if people like in the criminal justice system, like people who perpetrate crimes and are in prison, just the justice system in general, those people that have FASD, if they had a diagnosis, I think that would help a lot. Do you?
Well, again, I come back to Darren. You know that, you know what a diagnosis is in a sense that, okay, let me say, if I have a headache, I don't go to a neurosurgeon's surgery table. I take an aspirin or whatever to help my headache. Again, I'm coming back to that mild to severe piece. Yeah. If I break my arm, I don't have my arm removed. It goes in plaster Paris and it fixes. I worry that if we hang that somehow a diagnosis is going to change things, it doesn't, Darren. I don't know if you've ever been given a diagnosis, but it's a piece of paper. It doesn't change the issue. What changes the issue is the response to that diagnosis. And it's the in-services and the treatments that are applied to that diagnosis. What I'm saying is that where we don't have national guidelines on diagnosis, where I'm saying that the invisible aspect of fetal alcohol is there is no clinical guideline, we can be doing those assessments, we can be doing those services and approaches, because when I do an adaptive behavioral function assessment, it clearly shows where this professional is struggling. It clearly shows where the weaknesses are. When I do an executive functioning assessment, it clearly shows. Those are the things that actually influence how services then can understand this individual. So I worry that we just, if we're hanging everything on diagnosis, I mean, think about that. If we just had a process in Ireland by which we diagnosed cancer but didn't do anything with it, that's the same principle, yeah? That we're diagnosing but not responding.
So are you saying that the services in Ireland are far behind where they are, where you are living now in Boston?
I'm saying, Darren, unfortunately, globally, there is a paucity of good practice. Now, probably the most recognised good practice is the province of Alberta in Canada, which has a population of a little over 5.5 million, so very similar to Ireland in the context. In the early 90s, social workers and foster carers came together and they wrote to their MLAs, Member of Parliament, about the problems of fetal alcohol. And as a result of that, the state of Alberta now has 24 multidisciplinary assessment centres for a population of 5.4 million. Now, again, I think like in Ireland, I think I've seen recently there is an assessment centre opened in Dublin. I worry if they go too much down the clinical piece and they don't see the biopsychosocial or the social need, then it's going to be difficult. The other problem, Darren, is that I think you're aware that the Irish system is buckling at the moment. I saw a report last week that autism assessments are now 2 years waiting for an autism assessment. So with the whole neurodisability field, which are autism, etc., how fetal alcohol fits into that is going to be a major, major challenge. Now, again, I have submitted to Ireland the 5-step screening tool. When I did that, Darren, I intended to come back and train that into social work because I do it. It's very doable. And I wanted social work to be able to do that so that we would be addressing the needs of these kids at the point of presentation, not funneling them into clinics and into long waiting lists, but actually dealing with it as it presents. And I think that was the original concept of my research. But I think I've encountered some conscientious objectors in Ireland to me coming back and doing that training for social work. But if we just go around creating clinics, I'm saying it's not going to be long before we have long waiting lists for children to be assessed. I'm clearly saying that, unfortunately, the 5-step can be trained into frontline, and that's where it should go. And you could do the executive functioning, you can do the adaptive function, you can do the behavioural assessment, and it can be done within social work teams. It doesn't have to go into a specialist system because we likely have a high prevalence rate of fetal alcohol in our child welfare system. Again, given what the epidemiologists have said, my suspicion is that Ireland could be in the 35 to 38% of fetal alcohol in our child welfare system. Now, again, at the moment in Ireland, the state system has 5,800 children in the care of the state. So again, if you do the quick maths of what 35% would be, you start to see that there's a burden on the system. And that burden cannot be dealt with a clinic or with 2 clinics. It would be better to train the staff to actually do the neurodevelopment screening, like Dr. James Fitzpatrick acknowledged in the inquiry in Australia, is to do those neurodevelopment screenings in practice, in situ.
And who is the person or people who will be responsible for accepting your proposal? The Minister for Social Protection in Ireland, is it?
Well, again, I suppose, that again, it comes back to that point I made. It would be lovely to see TUSLA, HSE, Department of Education, Department of Health sitting down at a table. And if they did, I would love to come and present to them and say, look, this is the model, this is how it works, and this is how doable it is. And Darren, what people don't like me saying is actually very low cost. Steps 2, 3 and 4 cost less than €20 at base cost. Now, I know that there's professionals that deliver it and therefore have costs attached to that. But the child behaviour checklist is €2. And yet it tells me so much about that child. And it tells me so much that I can direct a treatment and I can direct a plan on that. So we can throw the baby out with the bathwater concept by not acknowledging something that is low cost, that is doable and is pragmatic. But because it's within the social model of disability, it may be viewed with contempt or it may be viewed negatively. Because we are caught in a heavy medical model of fetal alcohol.
There's at least one association in Ireland of social workers, though, isn't there?
Yes. Well, the Irish Association of Social Workers is the main body, yeah?
I'm saying, like, have you spoken to them about what your idea?
I mean, a number of social workers in Ireland have reached out to me for help. And so because through social media, through LinkedIn, they've reached out because they have a difficult case. I've talked to them. I've sent back paper, blah, blah, blah. I've recently sent in a model of what I do in terms of assessment. I've sent that in to TUSLA to say, I'm here, I can do these assessments. Now, again, the confusion there is like, if I'm in Boston, how can I do the assessments in Ireland? The assessments are done on a digital platform. So they're not, I do a connection with a caregiver, whatever, through, it's a thing called DoxyMe. It's a HIPAA approved. HIPAA is the confidential aspect of services. And so TUSLA has to be confidential around how they share that information as well. So I do those assessments and I can do the assessment that I just done is for a family in Iowa here in the US, which is thousands of miles away from me. But I've done that. I'm returning it tomorrow. I will have a meeting with them. And I know from the assessments I've done, they're going to be chuffed. I'm chuffed what I'm seeing in the assessment, what the outcome is. No, I want to just, I want to kind of put out a kind of call to social work in Ireland that please read Capture Invisibility, the paper. If they struggle with the 5-step, to reach out to me and I can explain how the 5-step is applied in practice. I'm a little, I've seen some plagiarism of my work and I'm a little worried that, people are plagiarizing but then setting themselves up and charging people to come to the training. That is not what I intended for my work. My work was meant for social work and it was from social work. And I think the key aspect of that is that the 5-step model, which is in that paper, Capture Invisibility, it came from Irish social work data. It came from the front line in Ireland. And it needs to go back to the front line in Ireland in that respect. And so I think there's a poor understanding perhaps in Ireland as to why social work need to be elevated in the discussion. But I'm saying to you, and I'm saying to the listener, no child appears in foster care or adoption through osmosis. They come through that intake process. That intake process is the vital piece in the jigsaw that we need to address because it's there that we potentially can start to identify this hidden disability in terms of, and then make appropriate thing. Again, it's hidden. But that's why the paper is called Capture Invisibility, because we are looking to capture that hidden disability. Again, I come back to say, if the 5-step is done correctly, it does capture. And it captures the 9 domains of brain functioning, and it captures it in the strengths and the negatives of the process. But again, I can understand that social work might look at this and think, I can't do that. Well, I'm just saying you can if you're given the training and you're given the supports to do it. And again, I suppose that comes back to TUSLA, to engage in with the process and to engage in, because I would like to train. When I'm dealing with social workers contacting me in crisis, it's a little frustrating, Darren, because I can hear their desperation of where they are isolated. They're not supported by the system, and they're trying to manage these complex cases with no support, no procedures, no guidelines. I said to you, Darren, I used to be a child protection trainer in Ireland, and I used to train children first, up and down the country. It was generally accepted then that children first and child protection was not be trained by anybody, that it was a state system and a state approach. I'm saying to HSE, TUSLA, whatever, it should be the same for fetal alcohol, because there's a high level of complexity, there's a sensitivity, there is a maternal rights issue within this. There are so many caveats that need to be considered in terms of how we address fetal alcohol in society. And it's not easy, and it's not. And again, I'm saying, talking to social workers, I feel they're struggling, you know?
Like, if any politicians, I'm thinking particularly of the Minister for Social Protection, I believe that's Dara Callery, like, if any kind of senior politicians, including in government, took an interest in what you're calling for, it could make the world of difference, could it?
I believe so, and I think, you know, that I can only say, you know, I did an assessment on a little kid, 9 years old, about a year ago now, but at the point of intervention that I was brought in, Darren, this kid was being permanently excluded from the school, and the kid had the paperwork done to be brought into child and adolescent psychiatric services. I got involved, did my assessments, informed the school, brought the school on board with what I was doing, because this kid had a diagnosis. And this again is what I'm coming back to. That children are being diagnosed and then drifting into the system with no supports. And people don't understand it. So in this case, the school did not understand the diagnosis that the child had. I did the assessments, I did the process, etc., etc. The child turned around. They held off on putting them into child and adolescent psychiatric services. I think it was about 3 months ago. So about 7 months later, I got an email from the adoptive parents, and they could not say enough about how this had changed. It had done a 360. This kid enjoyed going into school. This kid was excelling in school. This kid was just loving life. Again, Darren, the assessment just showed where the deficits were. The treatments, the interventions went on the deficits. It allowed the strengths to blossom when you do that. And so, yes, this is a practical model that I believe can greatly, greatly assist in the system in Ireland. That we should not get hung up on diagnosis as the only option. Diagnosis is important, but in the 5-step model, diagnosis is step 6. And all I'm saying is that we should be asking questions before we diagnose. That we don't rush to diagnose and then ask the questions. I see too many kids coming to me after very expensive diagnoses now coming for the pragmatic screening tools. It does not make sense that it's reversed. I want to put the screening tools in first.
Okay, what kind of, if someone does have a diagnosis, what kind of services are there in Ireland, and what kind of services do you think should there be?
Again, I have to be careful and answer that one, Darren, because I'm not totally sure what services they have. I'm aware over the years of this work that many carers have tapped into autism services because there's certain neurobehavioral presentations that can be managed. Like, these kids have high problems with sensory processing. So a lot of the autism services do the sensory processing. So carers often try and cherry pick from the different services to make the service for the child with fetal alcohol. There is limited services, I would believe, post-diagnostics in Ireland. And I therefore say we need to kind of slow down on this medical model of diagnosis if we don't have the services that are there when the child is diagnosed.
I'm just curious as to what kind of services would in an ideal world be available. Like if someone has an FASD and they're in a bit of trouble, whether it's in school or work or education or whatever, obviously you have to have patience with such people, children, young people, adults. But is there any kind of hope for them, if you know what I mean?
I think obviously I'm saying that if they get the correct interventions, there's great hope for them. Like the kid I just explained, that he's done a 360 from where. I mean, again, I want you to think about, Darren, the cost to the state systems here, that we're not doing this intervention. A child and adolescent psych placement here in my area is going to cost thousands upon thousands upon thousands. Yet my intervention, which was kind of less than $500, actually completely 360'd the child's needs. So currently, fetal alcohol is costing $10 billion a year. That is a Canadian study in 2019, because fetal alcohol impacts across all the service areas. It's education, it's TUSLA, it's the child welfare piece, it's the criminal justice system. So the costs add up. And I'm saying that, unfortunately, we have the result, we have the knowledge, we have the resources. And I certainly say that I have developed something that I believe is a win-win for the system to look at in terms of implementation. No, I just want to thank people in Ireland that are supporting this work and that are supporting and are trying to move the needle forward. This is not a blame issue on women, and I want to be clear about that. I have absolute respect for birth mums, and I do think we just need to grasp this through a professional lens. And I think the state systems need to lead on bringing that home to a professional lens piece as well, because of the complexity. We should not be kind of allowing narratives to go out there that are going to stigmatize, that are going to hurt in the environment.
Okay, Liam, it's great talking to you. Thanks very much. This interview will be going out on the RFM on Sunday, either this Sunday coming the 7th or the following Sunday. And I'm not very au fait with this whole Zoom call thing, but just speaking of what you're saying for the last New Year, we do have a long way to go, don't we, when it comes to FASD in Ireland and around the world?
I think if the system would acknowledge the research and acknowledge what has been done, then that journey could be massively shortened. And we don't have to go on a long winding road of trying to figure out fetal alcohol. We acknowledge the empirical evidence that's in the system, and we work to implement that. And I think implementation is a word that I would like to leave this, meeting with. Is we have the tools, we have the knowledge, but we don't have implementation, and that's what we need to do.